Hi everyone, and welcome to our module on cervical cancer. Cervical cancer refers to cancer of cervical epithelial cells, and the vast majority of cases, about 97%, are associated with human papillomavirus. So when you're talking about cervical cancer, we're always talking about HPV infection as well. So human papillomavirus, or HPV, is a sexually transmitted cervical infection, and there are multiple subtypes of the virus, each given a number for a name. And in terms of cervical cancer, HPV 16 is responsible for about half of cases, and HPV 18 for about 20% of cases. And then beyond these two subtypes, there are a number of subtypes responsible for a small number of cases. And among sexually active women, there's a high prevalence of infection with HPV. Now, most women will clear the infection within 12 months, but some will have the infection persist. And it's these women in whom the infection persists that are at risk for cervical cancer. The area of the cervix where cervical cancer usually arises is called the squamocolumnar junction. This is the junction where the epithelium of the cervix changes from squamous to columnar epithelium. So the area of the cervix that leads to the uterus, the cervical canal, this is called the endocervix, and it contains columnar epithelium. The outer surface of the cervix towards the vagina is called the ectocervix, and this contains squamous epithelium. And so the junction where the epithelium changes from squamous to columnar, called the squamocolumnar junction, that's where most cervical cancers arise. If you look at this picture on the screen here, the dark beefy red area here is the endocervix, that's columnar epithelium, and you can see the line of demarcation where it changes to squamous epithelium, that's the squamocolumnar junction. You also should be aware that the squamocolumnar junction moves throughout a woman's lifetime. It can be further out or it can come back further in. And this area over which it moves is called the transformation zone. This is an area surrounding the squamocolumnar junction in which the junction can move during a woman's lifetime. It moves from exposure to hormones and other factors, and the transformation zone is the area between the original squamocolumnar junction and the new or current squamocolumnar junction, and 95% of cervical cancers arise here. It's related to the squamocolumnar junction. It's this area where the junction moves over a woman's lifetime. Just to make this very clear, on the left side of the screen is a histology image of the squamocolumnar junction. This is squamous epithelium of the ectocervix here, and this is columnar epithelium of the endocervix here, and this would be the junction right here. And then if you look at this drawing on the right side of the screen, the cervical canal in here has columnar epithelium. The outer surface of the cervix here has squamous cell epithelium, and this is the transformation zone, this blue area here, where the junction moves outward and inward over the course of a woman's lifetime. Some of the important risk factors for cervical cancer are shown on this slide. The major risk factor is human papillomavirus infection. Patients who are immunodeficient are also at increased risk because they can't clear the HPV infection if they do become infected. Cigarette smoking is a risk, so is sexual intercourse at a young age, multiple sexual partners, and a history of sexually transmitted infections. So now let's talk about cervical neoplasia, which can occur in women who have chronic HPV infection. And you should know that cervical neoplasia progresses slowly through stages until cervical carcinoma develops, and that's why we screen for this, because we can treat it in the early stages. The average time from HPV exposure to cervical carcinoma is about 15 years. Recall that the cervical epithelium has a basement membrane, which I'll draw here as a line, and it has cells piled on top of it. Initially, cervical neoplasia is contained by the basement membrane. We call that intraepithelial neoplasia. It's growing only above the basement membrane. When it breaks through the basement membrane, we then call it cervical carcinoma. As the neoplasia is growing within the epithelial layer, we can identify it by a biopsy, and there are a number of ways to classify the degree of cervical neoplasia. The first way to classify the neoplasia by biopsy is called the CIN system. CIN stands for cervical intraepithelial neoplasia. By this system, CIN1 lesions are low-grade lesions. They are very far away from developing into carcinoma. CIN2 and 3 lesions are high-grade. They are very close to breaking through that basement membrane and becoming carcinoma. The other system for classifying biopsy findings is the Bethesda system. This is the preferred system in modern practice, but the CIN system is still in wide use because it's been around for a long time. By the Bethesda system, lesions are classified as squamous intraepithelial lesions, or SILs. A low-grade SIL or an LSIL is a low-grade lesion far away from becoming carcinoma. A high-grade squamous intraepithelial lesion, or HSIL, is a high-grade lesion about to progress into carcinoma. And so you don't need to know how to classify these lesions based on their appearance under the microscope, but just to give you an idea of the biopsy findings, on the left is an example of CIN1 or low-grade SIL, and you can see that there are some abnormal cells, but mostly the epithelial layer remains intact and looks somewhat close to a normal cervical epithelial layer. On the right is an example of CIN3 or HSIL. You can see that the epithelial layer has been completely replaced by these abnormal cells with abnormal nuclei. This is a lesion that is high grade and very close to breaking through the basement membrane and becoming carcinoma. And so when cervical neoplasia breaks through the basement membrane, we call that cervical carcinoma. And most cervical carcinomas are squamous cell carcinoma, about 75%. A smaller percentage are adenocarcinoma. This happens when the cancer derives from the endocervix, which is that columnar epithelium lining the cervical canal towards the uterus. And cervical carcinoma almost always occurs in women with HPV infection, as I mentioned earlier. Usually it's women in their 40s or 50s who acquired it in their 20s and then were not screened. We'll talk about screening in a little bit, but if women are screened and they have treatment for precursor lesions, it's very rare for cervical carcinoma to develop. And this is a picture of a cervix from a woman with cervical carcinoma. Hopefully you can appreciate that this mucosa here is very abnormal looking. That's how it appears when there is carcinoma present. Usually cervical carcinoma is asymptomatic. It can present as vaginal bleeding. You can imagine that if the cervix looks like this picture on the screen here, it can easily become friable and bleed. Women can also have irregular or heavy menses. Postcoital bleeding is a classic presentation because after intercourse, that can irritate the cervix and that can cause bleeding when there is cancer present. And cervical carcinoma can invade locally to the bladder or the rectum, and this can cause symptoms in those organ systems. So now let's talk about screening for cervical cancer, and we'll start by talking about the Pap smear, also known as the Pap test. This refers to an analysis of a sample of cells collected from the cervix, and the idea is to analyze those cells under the microscope and look for koilocytes. Koilocytes are cervical epithelial cells with large darkened nuclei. They look like what's shown on the screen here. And when you see koilocytes on a Pap test, this is evidence that epithelial cells have begun to change in the cervix because of HPV infection. So importantly, this is not detecting HPV infection directly. Instead, it's identifying epithelial cell changes caused by HPV infection. And when a Pap smear test is abnormal, it's usually followed up with a colposcopy, which is an examination of the cervix. We'll talk about this in a minute. An alternative to the Pap smear for cervical cancer screening is HPV testing. This testing also analyzes a sample of cervical cells, but it identifies specific high-risk subtypes of HPV virus. It's not available in all locations. Pap smear is widely available, but HPV availability is more limited. And importantly, it identifies HPV infection only. It doesn't tell you if the epithelium has begun to change because of HPV. That's what a Pap smear will tell you. This will tell you only that HPV infection has occurred. And so there are two ways you can use HPV testing. One is called primary HPV testing. This means testing for HPV alone without a Pap smear, and this is rarely done. And the reason it's rarely done is because a positive test will only tell you that there's infection. It won't tell you whether or not cellular changes in the epithelium have begun to occur. The way HPV testing is more commonly used is as one element of co-testing, which means testing a sample of cervical cells for HPV plus doing a Pap smear. The way this works is if the HPV test is positive, then you know there's an infection present, and if the Pap test is positive, then you know cellular changes have begun occurring in the cervical cells because of HPV. And so in these cases, the testing is followed up with a colposcopy because you need to examine the cervix and do a biopsy to see how advanced the epithelial cell changes are from HPV infection. If, on the other hand, the HPV test is positive but the Pap is negative, then that means you have HPV infection but there are no cellular changes present yet. And in this situation, you can repeat testing in a year, and this allows you to defer colposcopy. The idea is the test is telling you that although HPV infection is present, the cervical cells have not begun to change. That's why the Pap is negative. So you can defer the colposcopy until cells become abnormal in the cervix. So this is a summary slide of the recommendations for when women should be screened. Different groups have different recommendations, and I've tried to summarize them all in this slide. So before 21 years of age, the guidelines recommend no screening. And the idea here is that before 21 years of age, cervical changes and cervical neoplasia are very uncommon. From ages 21 to 29, you can either do a Pap test every 3 years starting at age 21, or you can do HPV testing every 5 years starting at age 25. The guidelines vary depending on which group you're following. From ages 30 to 65, you can do a Pap test every 3 years, or HPV testing every 5 years, or co-testing every 5 years. And then beyond age 65, you can discontinue screening in women who have had 3 normal Pap tests or 2 normal co-tests. However, you may continue screening in certain high-risk individuals, for example, women who are smokers or women with other risk factors. And keep in mind, these are just guidelines and recommendations. Gynecologists will use different screening methods for different women depending upon their risk profile. There are a couple of special populations in terms of cervical cancer screening. For women who are immunosuppressed, they should begin screening at the onset of sexual activity, and they should continue it throughout their lifetime, even beyond 65 years of age. They can either have a Pap test done alone. This can be done every year, and then once they've had 3 years in a row where the Pap test is normal, they can begin to do testing every 3 years. An alternative is to do co-testing every 3 years. Another special group are women who've had a total hysterectomy where the cervix was removed. In these women, they have no cervix, so no screening is indicated unless they've had a prior abnormal result and you think that there may be cervical cancer cells that have remained behind after the cervix was removed. Let's talk about the interpretation of the results of a Pap smear test.